Okay, so we are talking about generalized pain, and when you take a quick look in the clinical practice guidelines, you will see that there's a number of low back pain conditions, including this condition, low back pain here, with related cognitive and affective tendencies. Typically, this is acute and subacute and relates to any of these conditions that you see above. Any back pain condition or classification with a psychologic overlay, like depression, anxiety, or fear, can lead to a slippery slope towards generalized pain. What I want you to see here when you observe how the patient presents is that many times you may see inconsistent patterns of low back pain that don't match a classification that you would typically recognize, right? Sometimes flexion movements might make them worse, which mechanically makes sense, but then sometimes they'll tell you, hey, you know what? Sometimes my extension movements make me worse. Sometimes my leg pain is on the other side. Pain descriptions that are inconsistent with mechanical expectations or inconsistent with their movement patterns begin to make you wonder, are there other issues here? Right, because different structures now, the patient's beginning to complain of structures all over the place. Right, so point being that when you go into the physical exam for these kinds of patients, you really need to do a good job with the depression screen. Okay? Could they have movement faults? Absolutely. Many of them will have very faulty ways of moving, and really many of them will also have abnormalities in the region, so related to regional interdependence. It will be important in your interventions to do a lot of good education. Right? The guidelines talks about two main things not to say. Now, when you look at the clinical reasoning, the guidelines talks about doing a good bit of education. It may require a multimodal approach. Do not promote prolonged bed rest. Do not, and actually encourage them to go back into daily activities, return to function, as long as you've taught them to move properly. Remind them not to overdo things, and that they are not alone in this problem, that low back pain is quite common, really, and that their prognosis is generally very good. These are all guideline-based principles that help to counteract concerns or rumination or fearfulness, catastrophization that's going on in the patient's brain. Talk about how the spine is strong, help them understand the pain sciences, how tissues heal, and how pain, chronic pain can sometimes be related to an alarm system, so help them understand pain. All of this content is important and driven by the guidelines, so it will be important as a clinician when you recognize these signs and symptoms of affective and cognitive and affective tendencies to manage those with expertise in your education, in your training, and in the ways that you talk. To not talk so much about imaging and structures that might be injured. Okay, so all of this content is in here, talking about graded exposure and graded activity as well. So I think that is the main thing. There should be some conditioning built in. You can see that there's an overall cardiovascular program, graded activity with walking, and education, counseling, and graded exposure. So all of this becomes a part of the mark of a good therapist who can try to change the track of someone who may be headed towards generalized pain, but is able to recognize the signs and symptoms and do a good job with education and reducing fear. All right, so that's just a quick glimpse of looking at back pain with cognitive and affective tendencies and generalized pain in clinical pattern recognition, low back pain.